Thank you for joining us today. Welcome to our Data to Drive Decisions webinar. Our topic today is investigating the impact of COVID-19 on health systems and Medicare patients. I will introduce our panelists here in just a second. Just a little housekeeping before we get going. Everybody is muted currently. We would really welcome any questions in the chat box, so use that as you will. We'll take questions throughout and then also at the end. We are recording this webinar. Stay tuned. We're checking to see if it's okay to share this data because the authors are in the middle of submitting to a journal. So there are some requirements that they're checking into to see if this will be recorded, but enjoy it as you have the opportunity to see the information today. We are excited to have presenters from Harvard and the National Bureau of Economic Research. We have David Cutler with us today. He's a professor of applied economics at Harvard University, and he's joined by his colleague Kaushik Ghosh, who's a research specialist at National Bureau of Economic Research. I'll be facilitating today's webinar. My name is Carrie Frank. I'm the Vice President of Communication and Marketing here at the Center for Improving Value in Healthcare. So quick agenda, we'll talk about just the CIVHC and the APCD really quickly in case you're unfamiliar with who we are. And then we'll turn it over to our presenters to talk about the research they've done on changes in morbidity and mortality specific to utilization and the health of Medicare beneficiaries nationally associated with the COVID pandemic. And then there'll be a specific focus on assessment of whether there are any changes, whether patients were seen by health systems or non-health systems. So really quickly about CIVHC, who we are, we're a nonprofit organization. Our mission is to empower individuals, communities, and organizations through collaborative support services and advancing the health of Colorado through data support. And really everything we do is focused on better health, better care, and lowering costs. We're objective and independent, as I mentioned, a nonprofit organization, and we serve a wide variety of stakeholders who we call change agents, and those are folks on the ground who are working to improve healthcare, make Coloradans healthier. That spans the range for researchers who you're going to hear from today, government agencies, health plans, hospitals, employer groups, and clinicians, all with the focus on the consumer in the middle and improving the lives of patients. We inform through data, both on a public basis and non-public basis. We have a wide variety of public analysis that are available online. We're not going to talk about any of those today, but we've done many features, and our next webinar is going to feature one of our key public reports, which is our Shop for Care tool. And we also have non-public reporting that we provide to those change agents we were just talking about. And that's through our license process where we provide information to help others address the AAA. Just a little bit about the APCD. We do have a significant number of claims. We're quickly approaching 1 billion claims in the database. We have data from 2009 all the way through 2020, and that's across 44 payers. That's including commercial payers, Medicaid, Medicare Advantage, and Medicare fee-for-service. And it encompasses the wide variety of stakeholders and patients in our state, and the vast majority of patients in our state. So that's just a little bit about us, but I know you guys are here to hear directly from our presenters. So I'm going to go ahead and pass it over to Dr. Cutler. Thank you again for being here, and I'll let you take it away.
Well, Carrie, thank you so much for having me. Let me just make sure you can hear me okay.
We can. Thank you.
Awesome. So it's a pleasure to be with you. I know I've known for some number of years about CIVHC, and it's really it's a treasure of an organization. It's really a wonderful group, and you do fantastic things. We in Massachusetts look longingly at what you do. We hope people around the country look a little bit at what we do, but I'm just delighted to be able to participate in an event with CIVHC and to help out the just absolutely fundamentally important work you do. So thank you for that from way across the country. Thank you so much for all of that. I'll do the presenting today, although I do have partners in crime. So one of the partners in crime is Kaushik Ghosh, who's here. As a rough rule, if there's anything that you like about the presentation, feel free to blame Kaushik. And if you ask him, everything that you don't like is due to me, although we might have a little bit of dispute about that. But Kaushik is a sort of terrific person. And by luck of the draw, I'll just do the presentation today. Nancy Beaulieu is a colleague of ours. Nancy is a research professor at Harvard Medical School, and she's just not able to physically make the call today, but is here in spirit. So the title of the talk is "How Did Health Systems Survive COVID?" And then let me tell you a little bit about what it is that we're doing. And Kari, maybe what I'll do, since you're controlling the slides, I'll just give you like a little thing like that when I want to move on. That way I won't have to keep saying so, and then at least one person will be watching me. So COVID was an enormous shock, both to the medical system as well as to the health of the population. And so the question that we want to ask here is kind of, how did it affect the medical system? And in particular, how did COVID affect the ability of the medical system to address the care needs for critically ill patients? So were some medical care organizations and some medical care arrangements better able to withstand COVID and keep their care the way they wanted it to than others? If so, which ones? We're going to delineate the world into whether the patient was cared for by a health system or not a health system. So technically the title isn't quite right. How did health systems survive? We're going to define some systems and some non-systems, and I'll give you what exactly that definition looks like, and I'll tell you a little bit about what it looks like in Colorado as well. But that's what you want to think about is, if I was in a more organized system of care, did I do better during COVID than if I was in a not organized system of care? What we know overall, oops, we skipped one. What we know, thank you. What we know, nope, there we go. What we know overall is that 2020 was extremely rough, extremely down on medical care utilization. So what this chart is showing you, and you'll see a lot of charts like this, so I'll just sort of give you a kind of a headline to what these look like. Each data point here is a month for 2020 relative to 2019. And then what you're seeing here is the kind of percent change in 2020 relative to 2019. So just for example, to take an example, the yellow line is what's happening to E&M visits, to management visits in 2020 compared to 2019. So the first 2 months, it obviously looks about the same. That is compared to January and February of 2019, January and February of 2020 were about the same. And then you see, of course, the immediate impact of COVID, which is in March, April, and May. And you just, a very big decline in E&M visits. The blue line is inpatient visits. And then recovery starting in June, particularly for E&M visits, a little bit for inpatient visits, but not back to where they were, nor any filling in of the hole. So if you thought, what might have been seen, like if it's a really bad winter day in Massachusetts, what happens is nobody goes to the doctor for their outpatient surgery, but they reschedule it for a couple of weeks later. So you sort of see a bump up afterwards. And here you're not seeing that at all. Here you're just seeing the decline. So this was the first year that we've ever recorded that medical spending fell in 2020 compared to 2019. And the real question is that we want to ask here is how, what were the implications of that, and how did different systems manage, different types of arrangements manage to do that? So that's where we're going here. I've used the word health system a lot. And so what I want to start off by doing is defining that term for you. So that's what I want to do here. The NBER, so I'm a professor at Harvard. I also work at the NBER. I should say, like CIVHC, the NBER is a not-for-profit organization. It is not strictly devoted to healthcare. So it studies the economy as a whole. And its goal is to provide empirical information to help understand the economy. It does nothing formal, although one thing informally, just for your edification, not related to this at all, whenever you hear like the economy is in recession and the economy is in expansion, the US government relies on when the National Bureau of Economic Research declares the economy to be in recession or expansion to make that determination. So that is its sole basic mission in life, or official mission, but generally what it does is supports research. So Kaushik and I, along with a number of others, have been involved with the Center of Excellence on the clinical and economic consequences of health systems. That is, which type of healthcare arrangements are better than which other types of healthcare arrangements, and what can we say about them? So we've developed this definition as part of that. And so here's how I'm going to define a health system. So I'm going to define a health system as something with at least 50 total physicians at least 10 of which must be in primary care specialty. So it's not like a group of 50 cardiologists or oncologists would not be a health system. There must be at least one general acute care hospital. So we're not going to have systems of just children's hospitals here. At least one general acute care hospital serving adults and offering a broad range of inpatient services. And then finally, there's a minimum set of providers located within at least one hospital referral region. So it can't be that, you have one little outpost in Colorado, one little outpost in California, one little outpost in Massachusetts. And, and in total it adds up to 50, but you don't meet that in any area. So there has to be at least a minimum number in that area. So some providers are part of health systems. Obviously, if you're very small, you're less likely to be part of a health system. We flow through here all the ownership relationships. So a big part of this is not just, is my specific place where I practice, there may be 3 doctors or 5 doctors. But if we're part of a system, we have done the best that we can to trace all those organizations. So we know that, Medical Associates of Cambridge, Massachusetts, we've gone through massive amounts of data to try to determine whether Medical Associates of Cambridge, Massachusetts is owned by Massachusetts General Hospital. And if it is, then it'll get to be part of the Mass General Hospital or Mass General Brigham's health system, independent of the fact that that particular outpost has 3 specific doctors. That is, the data challenges here are actually quite substantial in that, there's not a single source of data that knows where these are from. So we get some of this from Medicare data, like Medicare has to know where to send checks to people. We get some from nonprofit forms that have to be filed, like Mass General is a nonprofit, so it files a form saying what it owns. We have data from physician surveys, groups that collect information about physicians. We have data from for-profits. We have their SEC filings and things like that. We sort of throw all this data in a blender. We push the stir button, and then out comes a set of health systems that we then try to check as best we can. So that's what's going on here. As I said, I'll show you a little bit about that. But let me deal first with this question about whether we think health systems should be better or worse than care in non-systems, particularly in a pandemic. So of course, we started this many years ago, and the idea was to say, are health systems better or worse than non-systems just in general? And then as COVID came along, we said, look, we really, really want to understand, like, where does the best care come in a pandemic? And you could think of reasons why being in a health system would be better for patients, and you could think of reasons why being in a health system would be worse. Obviously, access to financial resources is very important when you're losing a lot of money. I showed you the reduction in volume of patients. The patients, of course, who are not coming in were the ones who are particularly profitable. So that's that really, elective surgeries and imaging and things like that. So that really reduced the profitability of a lot of care providers a lot, which means that financial resources are a good thing to have. Also, good access to acute care. So we know they have at least one general acute care hospital. So if people need acute care, they maybe can coordinate better between the docs and so on. On the other hand, when you ask around, or when you think about it, there are areas why health systems might be worse. They might be focused more on inpatient care than outpatient care, particularly in a pandemic when all of a sudden you've got to think about really sick people. So it may be that Medical Associates of Cambridge, Mass, if it's on its own, spends its days thinking about, how do I get these patients to make sure that they're getting the care they need? Whereas, Health System, Inc. spends its days thinking about how am I going to make sure my hospital is running okay, and not so much thinking about the outpatients. And perhaps they may be more specialist care than primary care focused, and it may be that primary care is what you need for most patients in a pandemic, and specialty care maybe only for a few. I'm not saying either of these are right. This is just kind of how we went into it in terms of the theories that we had going into it. So that's sort of what we thought about. I told you all of this goes into a blender, and then we identify health systems. So let me just tell you a little bit about what it is that we've identified, and then show you some summary statistics about it, and then really get to how care was provided. So we found 700 odd health systems. So remember, a health system is, you can be in a system or you can be not in a system. So we identified 700 odd health systems in 2018. The vast bulk of hospitals are in health systems. So if you look down at the bottom, there are 3,400 general acute care hospitals that are members of health systems. Primary care physicians, specialists, you can see down there, a lot of them are in health systems. Not so much on the patient end, and I'll show you some statistics on the patient end, but certainly on the provider, and many of the sort of biggest providers are in health systems. We have delineated them by type of system. Obviously, you can be more than one, but we've sort of done a hierarchy. So here's the kind of hierarchy we've done up top here. If you're both like nonprofit and academic, we'll call you an academic one. So just sort of giving you there, and you can see a kind of a bit about what they have, ranging from academic systems to public hospital systems. Denver Health qualifies under that. HCA is a for-profit system, and then other private systems and so on. So this is the nature of the health systems. Let me just give you a little bit of sense so that you see what these look like. Let me just give you a little bit of sense of the Colorado area, so you can tell me if these look right or not. I made them right. If they're wrong, it's because Kaushik put them in the chart the wrong way, much against my better judgment. So there are 113 hospitals in Colorado. The exact number varies depending on what you count as a specific hospital, but that's based on how we're counting them, the number of hospitals. A bit over half of them are in systems, and a little bit under half are not. The system hospitals are much bigger than the non-system hospitals. So, it's got to be around 3/4 or so on the right of the beds in Colorado are in health systems relative to not in health systems. And if you look at the ranking of the health systems by the number of beds, you can see the biggest one that we identify in Colorado is HCA. And then we have a number of other ones there. I should let you stare at this for a minute to see whether you think it makes sense to you, but that's what we have. While you stare at that, I will say that the biggest hospitals that are not in health systems are on the right. Remember one of the things that I pointed out about it is that you have to have at least one general acute care hospital. So that's why the children's hospitals, which otherwise would meet the criteria, are not in health systems here. So this seems like a good place for me to pause just for a minute and just see whether people are comfortable with what happens with what I've been talking about so far, because from here I'll go on and I'll talk about the data and the research strategy.
And again, feel free if you're joining us to type into the chat box, and if you have any questions or comments on the arrangement of health systems in Colorado.
Actually, I'm going to just to make sure everyone's okay, everyone's awake. I'm going to ask a question for which there is a required answer in chat. Okay, so here is your answer. Which was care better in the pandemic in health systems or outside of health systems? Okay, so that's your question, and you are required to answer in the chat. Ooh, we're running roughly 50-50. Kari, by the way, what do you believe is the correct answer?
Ooh, putting me on the spot there.
Yeah, pretty much.
I would say health systems.
All right, well, we'll see in just a couple of slides whether you're correct or not. The hint, by the way, is that that's actually right. Where is University Anschutz in this chart? We'll have to look and see specifically on some of them. Okay, so let me then go on to tell you how we've gone about doing this. So let me jump to the next one. So the data that we're using to look at this is Medicare data. So we have access. There's a kind of virtual data center where you can get access to very recent data from Medicare. So we have access to the universe of claims on patients in fee-for-service Medicare. We have all of their hospital, outpatient, doctor visits, and so on. So it's about 33 million people. And we're going to use information from 2019 and 2020. We're going to have various measures of utilization, the full range of stuff that you're used to seeing here. And then because Medicare needs to know when to stop paying benefits for you, they need to know if you're alive or not. So we have information on when the person died, if they died, and so we'll be able to show you mortality rates. The timing of what we're going to do is actually fairly simple to write down, although the execution is actually somewhat complex. And so Kaushik did a fantastic job figuring out how to do all of this. So we want to see basically where compared to 2019, in 2020, what happened to care for people in systems compared to people not in systems. So relative to how they were doing beforehand, who did better in the system versus not in the system. So what that requires us to do is to assign patients to systems. So what we do here is we have an attribution model. So in 2018, we take everyone who will be in our 2019 cohort, and we attribute patients, everyone who's alive through the end of 2019, we attribute them to a system, or to a system or not. We do that by where did they get the bulk of their E&M visits. So we see which doctor got the bulk of their evaluation management visits, and then we say, okay, that doctor is their primary care doctor. On the basis of that, what do we know about where their primary care doctor works? So therefore, is their primary care doctor in a system, and which type of system is that primary care doctor in? So we do that for everybody in 2018, and then we hold that constant. We say, okay, going into on January 1st, 2019, we know you were in a system or not in a system. How did your care fare? What kind of care experiences did you get, and so on. For the 2020 cohort, we do the same thing. In 2019, we use the same attribution rules to assign people to a health system or not, based on where their evaluation and management codes are. And we then look at their outcomes in 2020, where here sometimes, I won't show you too much about this, but sometimes we divide things into the two phases based on where I showed you care declined a lot versus where care didn't decline so much, although by and large, I'll sort of group them together. There isn't that much of a difference to them. So what I'm going to do is look at the use and outcomes for the folks who are in the 2018-19 cohort, the pre-COVID cohort, and I'm going to compare those to folks in the COVID cohort. Some of them are the same patients. Some of them may have switched from a system to a non-system or whatever, but I'm going to treat them as two groups, and I'm going to analyze the later time period relative to the earlier time period. And so then we're going to look specifically we're going to look at the population overall, and then we're going to look particularly at vulnerable populations. And we're going to define that in several ways based on prevalence of chronic conditions, patients who are racial or ethnic minorities, patients who are dually eligible for Medicare and Medicaid. We'll also have some information at the zip code level about the social deprivation of the area and or rural urban zip code. That's going to turn out to be important for things like telemedicine and stuff like that, which obviously will vary geographically. Okay, so let me then tell you a little bit about the patient characteristics, those in a system versus not in a system. So the first slide shows you that, remember I told you that the vast bulk of hospital beds and the vast bulk of, and many, many doctors are in health systems. The vast bulk of patients are, like 2/3 of patients are not attributed to health systems, I'll use that terminology, but to be slightly more precise about it, the doctors to which the patients are attributed do not belong to health systems. Now, that doesn't mean that none of their care is provided by a doctor in the health system. So maybe their specialty care is, but based on their primary care, their doctor is not in a health system. So that's about 2/3 of the patients. Just to show you a little bit of the characteristics of them, health systems treat a little bit of a lower percentage of male and minority patients than do non-systems. Health systems are far more predominant in, let's say, the northeast of the country, and particularly in the Midwest. And non-system patients are much more likely to be in the South and in the West. So think of kind of North as being more system-oriented in the country and South as being somewhat less system-oriented. And health system patients are far more likely to be in urban areas. That's not surprising because that's where you'll have groups of hospitals and doctors that will tend to come together. In terms of their chronic conditions, they tend to look fairly similar. In general, the patients who are in health systems have a little bit more reported chronic disease than do patients not in health systems. I don't know whether that's really true chronic disease or whether they're just more likely to report it. So there are certain things that, you get paid more if you do various things or if you report certain things, and they may be more likely to do that in the health systems. But that's on the basis of kind of what their background characteristics look like here. Okay, so that sort of tells you about the methodology, and it tells you about a little bit about the data. So now what I'm going to do is I'm going to show you trends in various kinds of outcomes for patients who are treated by doctors in health systems versus those treated not by doctors in health systems. So again, this is showing you, so this is coming back to that same chart. So this is showing you for 2020 relative to 2019, what's happening to care for them. So the first things that we looked at were kind of inpatient type care episodes. Like, was there any change in the propensity to use various forms of inpatient? And these charts are going to get a little bit crowded, so let me just explain to you kind of what's going on here. This time there are two sets of controls. So the blue lines are inpatient visits, so hospital inpatient visits. The solid blue is in system, so solid's always going to be in system, and the dashed is always going to be in non-system. And you can see those two blue lines look very similar. So there's basically no difference in the propensity to become hospitalized in a system. I should say that these are just the raw data. We have done sort of adjusted versions of these raw data, like, regression versions that correct for various sorts of things. And none of that seems to make much difference here. So I'm just going to show you the raw data, but assume that everything I show you in the raw data is true when we control for various background characteristics. What you saw is that those are not that different, so that they're not going to make that much of a difference. The area on this chart where we do see a difference is in the skilled nursing facility visits. So one of the things about SNFs is that it was down a lot. Like, if you look through, September or October, SNF visits are still down in the range of 10 or 20% relative to where they were a year earlier. But they're really particularly down for the system, for the people in the systems, and much less so for people not in systems. We don't totally know what's going on here. One suspicion is that, one hypothesis that we want to look at is that, people were generally afraid of going into skilled nursing facilities. And it's possible that beforehand, the systems were more likely to say, yeah, whatever, we're going to discharge you, go to a skilled nursing facility. And that it's possible they then had more room to cut when we said we don't want people going to skilled nursing facility, after they've been in the hospital. So maybe we could set up arrangements for them to get care at home, or maybe we could make sure that nurses are there or something. So it may be that they had more room to do changes there. Obviously, we have to look at the sort of levels, not just the growth from year to year to look at that. But that's one possibility. But the sort of interesting thing here is the difference between them. The other point about it is that some of the non system patients, that some of the skilled nursing facility use may be for COVID. And so we want to take this and we want to separate out the COVID part of this from the non-COVID part and see what's going on with that. Okay, so that's the first one on the skilled nursing facility end. We then look at various other measures. The yellow here, the sort of yellowish one, is outpatient visits, which look very, very similar between the systems and the non-systems. Again, they're both down a ton, and then they come back near where they were. You read these percents for these ones off the left-hand graph. The blue ones are office visits. These are sort of in-person office visits, and you can see they look very, very similar for systems and non-systems. The biggest difference, in addition to the skilled nursing facilities, the only other super big difference that we see in care utilization is in telehealth. And that's what the black lines are here. The black lines show you that telehealth went up for everybody. You read this off the right chart, it went up for everybody, but it went up a lot more and stayed higher for patients in health systems. So that's in terms of the utilization of care, that's the one that I actually think that I think is probably the most interesting here. I don't understand the SNF one yet, but I think it's interesting. But the one here that I think is most interesting is that telehealth rose everywhere, but it rose much more for patients whose physicians were inside of health systems than were outside of health systems. And that's true controlling for all sorts of stuff about where the background of the patients and the clinical conditions of the patients and things like that. So telehealth is one of the sort of significantly big findings here. We've looked at all sorts of preventive healthcare services. We will, in various iterations, show various parts of them. Here we're just looking overall. Preventive healthcare use fell in the first part of COVID. It then recovered some, particularly associated with immunization, pneumococcal immunization, Hep B immunization. Looked like people were coming in. There was a sort of respite from COVID for a while, and I think many doctors rightly took advantage of that to say, come in, I got to get you immunized for the winter. Come on in, please come on in. Let's get you, let's see if we can get you set set for the winter. The ED visits actually look very similar. So it's not that we're seeing here, like one thing that we had thought about is, maybe patients were differentially able to get their medications and, heart disease, heart attack rates would have been different inside the system and not inside the system and so on. We actually don't see anything on ED visits, and we don't see anything going back on the inpatient visits. And even when we look at specific things like cardiovascular and stuff like that, we tend not to see that. So it looks like most everyone was able to the same extent, address care like that. In fact, overall ED use, as you can see here, was down, as was overall inpatient use. That doesn't mean there wasn't anybody who was harmed, but just that there was nobody different by the systems or not who was harmed. When we look at the outcomes, the patients who are in health systems, so this is again 2020 relative to 2019. So you don't want to think about, who's sicker here, because I've kind of taken that out in the 2019 part. The patients who are treated in health systems tend to have their mortality rate increase by less than the patients who are treated not in health systems. So like, for example, the spike in mortality is lower for the patient in April in 2020 is lower. And then really throughout the year, throughout most of that year, the mortality rate for the patients in the health system is lower. I don't think I can say, oh, that's because of the telehealth, or that's because of the not being sent to a SNF, or whatever else it is. But that's just kind of the fact about it. And then the interpretation, I think, is something that that's a possible interpretation, but that's not the only possible one. So between the telehealth and the mortality, it's kind of painting a picture, at least, of the facts that one then wants to try to understand. We looked, I told you we looked specifically at various types of screenings, because we were really, really interested in this issue about, what happened to people's preventive care. So this is showing you 4 different types of cancer screenings: breast cancer screening through mammography, prostate cancer screening, colon cancer screening, and lung cancer screening. These are, again, changes from 2019 to 2020. Here we don't see very much of a change at all, actually. Not those 2 lines like almost entirely overlap. One good point, one bad point about them, even if we take them as a whole. The good point is that, after a couple of months down, basically screening rates look like they fully recovered. So screening rates in August and September 2020 were basically at the rates in August and September 2019. So that's the good point. The bad point is that sort of Grand Canyon of a gap there never got made up later. So what you might have been hoping for is that you would see, Mount Rushmore, or Mount Everest, in October to match, the deep underwater sea trench. This analogy is really, really not going well. So that you'd see, you'd see the sort of recovery in September, October, after the drop down in April, May, and June, and we don't see that. So it looks like whatever those screenings were, they basically just didn't happen. So and then people came back and they got screenings, but they didn't make up for the missed ones. So overall screening in 2020 compared to 2019 was down, even though after a few months it sort of recovered. We looked some at who is using the telehealth, and the good news here is that some of the most vulnerable patients were much more likely to use telehealth, both inside of health systems and outside. So if you look at dual eligibles, people eligible for both Medicare and Medicaid, both inside systems and outside systems, they were more likely to use telehealth. Urban patients were much more likely to use telehealth than were rural patients. And, so you can see there the highlighted row showing that the urban patients, again, both inside of systems and not in systems, were more likely to use telehealth. Not so much of a difference by the say social deprivation index, but again, the sort of glass half full part is it doesn't look like the sort of Q1, the worst social determinants areas. It doesn't look like they had no access to the telehealth, right? What you would be worried about is, people who live in the richer suburbs of Boston get to telehealth, and people who live in the poorer areas of Boston don't get to telehealth. And that doesn't look like what's going on here at all. It looks like kind of everyone got telehealth. And so I think of this as being pretty good about about the use of telehealth. And you can see, for example, African Americans were just as likely to be represented in telehealth services as in non-telehealth services. That's true both in systems and non-systems, and so on. So thankfully, the medical system seem to have done a very good job trying to keep trying to keep care going to those who really need it a lot. Similarly, if we look at the people with medical conditions, and we see, who wound up using telehealth, the single biggest thing here is in the middle, that mental health row. So an enormously large share of mental health visits took place by telehealth rather than in person. There's no reason why that can't have occurred. That was one of the things that people always thought could be fill in the blank was telepsychiatry, and that's a sort of a very big one. And it's kind of very, very nice to see that. You also see it for many of the others. Diabetes patients were much more likely to, respiratory patients, kidney patients. So a lot of these patients with chronic disease really wound up getting telehealth for at least some of their services. And that's, I think, a very good statement about the health system, even health system as a whole. That's true both in systems and outside of the systems, even though, as I was telling you, inside the systems, they went into it even more. It turns out, like, you would have been horrified if you found that it was sort of generally healthy people who had a lot of money and lived in rich areas who could get telehealth, and people with a lot of chronic disease and so on weren't able to do that. That's not what we're finding, and so thank goodness for that. So I will then just show you the summary slide, and then I will end. So the summary slide is that health systems do better at telemedicine, keeping patients out of skilled nursing facilities and lower death rates, and that telemedicine use increased more for some of the most vulnerable patients. That bottom part is good. The first part, as we noted, and as you noted, there are a lot of different theories about, so we want to explore some of those theories in more detail, but I fear you're going to have to invite us back to hear a little bit more about that. So I'm going to stop. Kaushik and I will happily answer any questions. You may say you're sick of me and you want to hear only Kaushik, and that's totally fine as well. But let me end it off here, and just with a repeat, thank you so much for inviting us.